We're going to wait a couple of minutes so that a couple of our participants can come into the room. And so we will commence the session in 1 or 2 more minutes time. So we will be back with you in 60 to 120 seconds. Thank you. So a very good morning and welcome to you all. My name is James Fitzgerald. I'm the Director of the Department of Health Systems and Services here at the Pan American Health Organization. And we are really happy to have you all join us this morning for the first webinar on the Essential Public Health Functions series. This is a series that the organization has organized to really begin to re-examine and expand our vision of public health to really based on strengthening health systems and improving public health throughout the Americas. I wanted to begin by thanking all of you, our regional public health community, for being present here this morning. And I particularly wanted to thank some of our national health authorities who we have with us here this morning for taking the time to participate in this session. I wanted to recognize the Minister of Health of Argentina, Dr. Carla Visotti, the Vice Minister of Health from El Salvador, Carlos Alvarenga, and the ex-Minister for Health and the advisor to the Minister of Health in Peru, Dr. Fernando Carbone. In addition, we have health authorities connected from many of the countries throughout the region, far too many, unfortunately, to name here, but we want to really recognize and thank you for your participation here this morning. Our webinar today will have 3 guest speakers. We will start with a presentation from PAHO, facilitated by Natalia Houghton, who is our specialist on health systems and services analysis and monitoring and evaluation. Afterwards, we will hear from Theodora Swift-Kohler, who is a senior technician advisor on equality at WHO. And we're really pleased also to have Federico Guanais, who's the deputy head of the health division at the OECD. We'll then transition into a 30-minute question and answer session that I will moderate. Please note that during this time, you can submit your questions at any point via the chat. And at the end of the webinar, we'll receive some final remarks from Ernesto Bascolo, who is our advisor on health policy and who is leading the work here on the essential public health functions under the supervision and guidance of Dr. Amalia de Riego, who is our unit chief for access and services within the department. A couple of logistics notes. Please note that we have translation in English and Spanish, and we have international sign available for you. So please choose the appropriate language for your convenience. We're really also happy to have with us this morning Dr. Jarvis Barbosa, the Assistant Director here at the Pan American Health Organization. And I will hand over now to Jarvis for his opening remarks. Dr. Barbosa?
Thank you, James. Buenos dias a todas e todos. Antes de começar, quero agradecer-lhes em nome da OPF por sumarse a este webinar. Es un privilegio para la organización poder reunir a ese grupo de destacados y destacadas panelistas y participantes para intercambiar visiones y experiencias sobre diversos desafíos que enfrentan los sistemas de salud para alcanzar la salud universal. Ese es el inicio de un ciclo de webinars sobre la nueva versión de las funciones esenciales de salud pública que la OPS ha elaborado junto com expertos e escolas de saúde pública da região, e vários ministérios de saúde de los Estados-membros que também participaram desse desenvolvimento. Essas sessões mensuais permitirão profundizar diversos aspectos de políticas e ferramentas vinculados com temas conceptuais e práticos relacionados com o fortalecimento das funções essenciais de saúde pública em las Américas. Al cierre de la sesión de hoy, compartiremos el calendario de los próximos eventos, así como el sitio web, donde podrán acceder a los materiales de cada uno de los webinars. El pasado 7 de abril, celebramos el Día Mundial de la Salud, bajo la consigna de construir un mundo más justo, equitativo y saludable después del COVID-19. Son tiempos difíciles los que vivimos. Tempos de dolor por lo que nos van derrando e quitando a pandemia de COVID-19, pero também tempos de muito aprendizagem. Entre as ensinanças que o 2020 nos ha dejado, hemos aprendido que enfrentar a pandemia e atender suas consequências implica levantar a mirada e poner el norte en la salud universal, en el fortalecimiento de los sistemas de salud desde las funciones esenciales de salud pública y en superar las inequidades y barreras que las poblaciones más vulnerables sufren para ejercer su derecho a la salud. En definitiva, el tema de ese primer seminario. El enfoque de salud universal ha sido reafirmado por la OPS desde 2014. En ese año, e luego de um extenso processo de consulta, o Conselho Diretivo da OPS aprovou a Estratégia de Acesso Universal e Cobertura Universal de Saúde. Os Estados-membros reconheceram que entre os principais desafios pendentes era necessário enfatizar a necessidade de assegurar o acesso e, portanto, eliminar as barreiras que enfrenta a população para aceder a los serviços de saúde quando los necessita. Isso é muito importante, especialmente para alguns grupos mais vulneráveis, como os afrodescendentes, como as populações indígenas, como as populações pobres da periferia das grandes cidades da América Latina. Alguns estudos estimam que cerca de uma terceira parte da população em las Américas enfrenta barreiras durante a búsqueda da atenção em saúde, sendo maior a proporção em la população mais pobre. Mientras que el 23,7% da população com maiores ingressos experimenta barreiras, entre a população com menos ingressos, as barreiras durante a búsqueda de serviços de saúde são reportadas por el 31,5%. As consequências da falta de acesso são alarmantes. Para dar-lhes uma ideia da magnitude do problema, ao redor de 1,7 milhões de mortes se poderiam haver evitado em 2016 em nossa região de haver existido serviços acessíveis e de qualidade. Isto é o doble que as mortes reportadas por COVID-19 em las Américas em el ano 2020. Como poderão apreciar, a persistência de barreiras e falta de acesso põe em risco os avanços que ha tenido a região hacia el acesso universal e a cobertura universal em saúde. Assegurar o acesso pleno a serviços integrais de saúde, adequados, oportunos e de qualidade, é fundamental para o desenvolvimento humano. Os países da região se han comprometido com a estratégia e han começado a aplicar linhas estratégicas adaptadas ao contexto e às características próprias de cada território. A região conta com uma hoja de ruta para avançar e uma valoração maior da saúde como direito, pero enfrentar o reto maior requer uma abordagem multissetorial e com distintas capacidades de decisão e influência hasta los niveles más altos de los gobiernos. El reto mayor es avanzar con los procesos de reforma y transformación de los sistemas de salud que expliciten el derecho a la salud, superen la fragmentación y segmentación y aborden las inequidades y los determinantes sociales de la salud. Las soluciones a nuestros principales problemas se encuentran más cerca de lo que pensamos. En ese caso, en el primer nivel de atención. La atención primaria en salud ha sido reafirmada en la Declaración de Astana de 2018 como la estrategia central para alcanzar la salud universal. Pero los esfuerzos por transformar los sistemas de salud de la región hacia un nuevo modelo de atención basado en la atención primaria en salud han sido limitados y ha levado a que aún persistam las barreras de acesso mencionadas. E pior aún, que em alguns contextos essas barreiras se multipliquem. Por ello, em 2019, apresentamos o trabalho à Comissão de Alto Nível, Salud Universal no siglo XX-XXI. No siglo XXI. 40 anos de alma ata, junto com uma série de recomendações que os Estados-membros han assumido como próprias e convertido em um chamado à ação, um pacto por la atenção primária em saúde para a saúde universal. O Pacto 30-30-30, Atenção Primária em Saúde para a Saúde Universal, assumido por la OPS esse mesmo ano, pretende acelerar os esforços de la região para lograr la saúde universal e os ODS em 2030. Llama a transformar os sistemas de saúde, concertar esforços para eliminar as barreiras de acesso em um 30% como mínimo e invertir al menos o 30% do presupuesto asignado à saúde no primeiro nível de atenção. Eliminar as barreiras de acesso a los serviços de saúde é um requisito para alcançar a saúde universal e os objetivos de desenvolvimento sostenible. Pero ello supõe um sostenido e comprometido trabalho que devem afrontar os países com o apoio da maior quantidade de sócios estratégicos para invertir nas funções essenciais de saúde pública, promover a ação intersetorial, fortalecer a governança de los sistemas de saúde, aumentar o compromisso e a participação de las personas e las comunidades nesse processo, revisar a forma tradicional de desenvolver políticas e de planificar em saúde, cambiar a forma de pensar sobre as barreiras que impedem o acesso efetivo e o exercício ao direito à saúde. As funções essenciais de saúde pública renovadas se estabelecem precisamente para servir como hoja de ruta para fortalecer os sistemas de saúde e avançar hacia a saúde universal com equidade. Atacar as inequidades e eliminar as barreiras com essa hoja de ruta será, además, fundamental para fortalecer as capacidades de preparação, alerta e resposta às emergências sanitárias que vamos afrontar no futuro. A OPS ha assumido esse compromisso de los Estados-membros com o Pacto de Atenção Primária em Saúde e orientado suas capacidades de cooperação técnica para abordar as barreiras de acesso aos serviços de saúde. Cambiar a forma de pensar sobre as barreiras implica avançar hacia uma caracterização sistemática de las dimensões e tipos de barreiras. Não se pode superar lo que é desconhecido. Compreender como essas se manifestam em distintos territórios e como afetam de maneira diferente, segundo idade, sexo e condição de saúde prévia. E, em especial, como afeta a los grupos de populações mais vulneráveis, populações indígenas e originárias da região, afrodescendentes, niños, niñas e adolescentes, mulheres e pessoas LGBT, entre outros. E implica também alentar um desenho de políticas que tenha muito presente as inequidades e limitações ao exercício do direito à saúde que generam essas barreiras. Aproveitando o conhecimento acumulado nos últimos anos por vários colegas que estão hoje participando nesse webinar, hemos explorado las metodologias disponibles y desarrollado una herramienta de análisis que rescata los aportes de autores más recientes y las experiencias de reporte de barreras de la OMS. Hemos indagado sobre distintas herramientas no tan clássicas para a investigação em saúde, como as encuestas de hogar, que nos permitem extrair informação e monitorear a evolução de como se percebem e experimentam as barreiras em distintos países e territórios a lo largo del tempo. E hemos começado a apoiar os países em uma melhor compreensão sobre as múltiplas barreiras que enfrentam os grupos mais vulneráveis, como é o caso da população adolescente indígena em la região de Condorcanqui, Peru, os niños, niñas e mulheres em Honduras e as populações del Interland em Guyana. Em uns minutos estaremos compartilhando esses resultados com maior detalhe. Esperamos que isso seja um aporte mais para aumentar a evidência e o conhecimento e melhorar continuamente as ferramentas para medir, monitorear e caracterizar as barreiras de acesso. Este é o primeiro chamado de ação que creemos importante compartilhar. Aumentar a evidência e conhecimento sobre como as populações mais vulneráveis experimentam distintas barreiras no acesso aos serviços de saúde. A equidade, a solidariedade e o direito à saúde devem ser, nesse sentido, pilares de los sistemas de saúde e também estruturantes de las ferramentas com que evaluamos os avanços. A pandemia ha afetado em forma desigual a la população de la região e hoje, mais que nunca, esses valores devem estar presentes. Um chamado de ação a los tomadores de decisão, considerar os maiores desafios de equidade que nos han dejado a pandemia de COVID-19 e o potencial que as transformações integrales de los sistemas de saúde têm para abordar melhor momentos como este. E, por último, considerar a evidência e a análise de barreiras no desenho de políticas, tanto setoriais como intersetoriais. É fundamental contar com esse tipo de evidências e desenhar e implementar políticas que eliminem as barreiras geográficas, barreiras financeiras, organizacionais e culturais. As funções essenciais de saúde pública renovadas são uma excelente hoja de ruta para o desenho dessas políticas. Hagamos que as políticas de saúde em la era pós-COVID-19 nos acerquem cada vez mais a assegurar o exercício do direito à saúde para todos e todas e de alcançar a saúde universal. Como suele dizer nossa diretora, a doutora Carice Etienne, hagamos que universal signifique realmente universal. Los dejo com estes pontos introdutórios, pero a riqueza dessa atividade está em los aportes e experiências que nos compartilharão a continuação nossos invitados. Les desejo uma sessão exitosa e produtiva. Agradeço los ministros, ministras, ex-ministros, ex-ministras, funcionários de los ministérios, nossos colegas de las oficinas de países de la OPS e também aqui de Washington, que vão compartilhar experiências e fortalecer esse movimento que é muito importante para lograr efetivamente uma saúde universal na região. E felicito a todos que participaram do desenvolvimento, não somente desse webinar, mas desse esforço de renovar a iniciativa de las funções essenciais de saúde pública em nosso departamento de sistemas e serviços de saúde. Muitíssimas graças a todos e que tenhamos uma muito exitosa e produtiva sessão. Graças.
Thank you very much, Dr. Barbosa, for those very motivating remarks. I think Dr. Barbosa has really presented for us the clear linkages that exist between our quest for universal access to health and universal health coverage based on the primary healthcare strategy, the importance of strengthening the essential public health functions as a core component in leadership and governance within that context, and then the challenges we face really in addressing the access barriers within health systems. And that's a nice segue now into our presentation on access barriers that hinder the achievement of universal health in the Americas. Our presenter is Natalia Houghton, our colleague and specialist in health systems and services analysis, monitoring and evaluation within the Department of Health Systems and Services, and specifically within the unit on access and services. Natalia has a long career in supporting numerous quantitative and qualitative research projects in healthcare access and equity, in maternal and child health, and in infectious disease prevention and control. She holds a master's degree in global health from Georgetown University. And in her current role within the department, she supports specifically the analysis of the access barriers within PAHO member states. So Natalia, over to you.
Thank you, James. And I'm sorry, gracias, James. Y buenos días a todos y todas. Antes de empezar, me gustaría reconocer la contribución del equipo interprogramático que ha contribuido a esta presentación y también al trabajo de barreras de acceso desde la organización. Me gustaría iniciar la presentación con dos mensajes que yo considero que son claves. El primero es que el análisis de las barreras de acceso debería ser un proceso holístico, es decir, debería incluir la utilización de diferentes herramientas y marcos de análisis, y ya de eso nos hablará en mayor detalle Teodora en su presentación, y también así la utilización de diferentes fuentes de información, tanto datos cuantitativos de encuestas de hogar, datos administrativos y también datos cualitativos. Muy importante los datos cualitativos porque son los que nos permiten dar contexto a la información que estamos analizando y también entender con mayor profundidad cuál es la interseccionalidad que existe entre las diferentes barreras de acceso que experimentan los diversos grupos de la población. El análisis de barreras de acceso también incluye el monitoreo de indicadores trazadores que nos permiten dar una idea de cuál es el avance que tienen los países en la reducción y eliminación progresiva de las barreras de acceso. El segundo mensaje que para mí es muy importante es que el análisis de las barreras de acceso es un proceso que es posible de hacer. Es factible, de hecho, realizar este tipo de análisis y en efecto hay muchos países de la región que actualmente están conduciendo diferentes estudios para tratar de entender cuáles son las distintas barreras de acceso. Los ejemplos más cercanos a nosotros desde la cooperación técnica de la organización incluyen estudios que tratan de mirar cuál es la situación de las mujeres, por ejemplo, en áreas rurales de Honduras y Guyana, la situación de las mujeres migrantes, como también así la situación de las poblaciones indígenas en la Amazonía del Perú. Y también en el contexto tan difícil que estamos viviendo de la pandemia, incluye también el monitoreo de métricas que dan cuenta de la continuidad en el acceso a servicios esenciales de salud. Quizá entonces lo importante sería tratar de ver cuál es la situación, cuál es el grado, cuál es la magnitud del problema de las barreras de acceso. En ese sentido, los análisis de encuestas de hogar y de algunos indicadores trazadores, como lo son los de necesidades insatisfechas en la salud, nos dan una idea de cuál es la magnitud del problema. En efecto, lo que nos dicen las encuestas es que aproximadamente cada 3 de 10 personas en las Américas no buscan atención de salud cuando lo necesitan. Y en efecto, cuando uno compara ese panorama entre distintos grupos de países de la región, nos damos cuenta que la situación es peor para los países de ingreso mediano-bajo, donde el 44% de la población no busca atención de salud cuando lo necesita, comparado con los países de ingresos altos, en donde esa cifra es del 12%. Ahora, no buscar atención de salud tiene implicancias muy importantes. En efecto, aumenta el riesgo de mortalidad y morbilidad que es evitable si estuviese un acceso oportuno a los servicios de salud. En efecto, cuando uno trata de cruzar ambas variables, tanto la de mortalidad evitable como también así la del porcentaje de la población que no busca atención en salud, nos damos cuenta de que existe una relación. Y podemos ver, por ejemplo, en la gráfica que países que tienden a tener altos porcentajes de la población que no buscan atención de salud de manera oportuna, también sufren de altas tasas de mortalidad evitable. Y el caso contrario, están países, generalmente países de ingresos altos, donde el porcentaje de la población que no busca atención es más bajo y también así es la tasa de mortalidad evitable. Eso nos indica varias cosas. Por supuesto, la necesidad de mejorar la búsqueda de atención oportuna para poder tener un efecto positivo en las tasas de mortalidad, pero también nos demuestra la importancia de poder estar monitoreando este tipo de métricas que de alguna manera nos dan cuenta de cuál es la capacidad que tienen los sistemas de salud para mejorar las condiciones de acceso. Más útil todavía sería poder tener una idea de cuáles son las razones por las cuales las personas no están buscando atención, cuáles son las barreras que enfrenta la población. Y en ese sentido, las encuestas de hogar también nos dan un panorama muy interesante, nos indican un poco de cuál es la situación en los países de la región. En efecto, nos damos cuenta de dos cosas que yo creo que son muy importantes. La primera es que las barreras de acceso son múltiples, son muchas las razones por las cuales las personas en efecto no buscan atención de salud de manera oportuna. Y lo segundo importante es que esa experiencia de las barreras de acceso cambia de acuerdo al contexto particular de cada país. Y eso se ejemplifica un poco en la gráfica que les estoy compartiendo. Cuando miramos, por ejemplo, los países de ingresos altos, nos damos cuenta que una gran proporción de las personas experimentan barreras de tipo organizativas o administrativas, que también se llaman. Estas barreras constituyen, por ejemplo, altos tiempos de espera, horarios de atención inadecuados o procesos administrativos en la búsqueda de atención que son muy complicados para las personas. Ahora, si nos movemos hacia los países de ingresos medianos bajos, nos damos cuenta de que ese panorama es un poco diferente. Y en efecto, en ese grupo de países son las barreras que tienen que ver con la disponibilidad insuficiente de recursos, por ejemplo, recursos humanos, medicamentos y otros insumos esenciales para los sistemas de salud, los que representan la mayoría de las barreras de acceso. Pero también así son importantes las barreras financieras, por falta de plata para no poder pagar por los servicios de salud, las barreras geográficas y las barreras de aceptabilidad. Muy importantes son las barreras de aceptabilidad porque estas tienen que ver con las barreras lingüísticas que enfrentan diferentes grupos de la población, con el maltrato que pueden estar recibiendo durante la atención de salud, por las preferencias personales que tienen las personas, por ejemplo, por la medicina tradicional o alternativa. Todas estas barreras de aceptabilidad son también causas, son también parte de las razones por las cuales las personas no están buscando atención de manera oportuna. Entonces, ¿qué nos dice la información? La información lo que nos indica es que de hecho si queremos mover un poco la aguja hacia un avance, hacia la salud universal, hacia un acceso equitativo, es importante que las distintas políticas estén abordando cada una de las barreras de acceso que se experimentan por parte de la población. Lo otro que también es importante es poder reconocer que el contexto cambia de país a país y en ese análisis y en esas intervenciones de políticas es muy, muy importante poder considerar ese contexto también. El otro punto que también es súper clave es el de poder ponernos los lentes de la equidad, de reconocer que la experiencia de las barreras de acceso de hecho es diferente entre distintos grupos de la población. Y un poco así lo podemos ver en la presentación, donde nos damos cuenta que la población de los quintiles de ingresos más bajos, es decir, la población más pobre, experimenta con mucho mayor frecuencia las barreras de acceso geográficas, financieras, de disponibilidad y de aceptabilidad, con mucho mayor frecuencia que la población más rica. Ahora, si hubiésemos desagregado esta información por muchas otras variables socioeconómicas, nos podríamos dar cuenta que la experiencia de esas barreras de acceso es diferente, por ejemplo, entre los distintos grupos de mujeres, entre los hombres, entre, por ejemplo, la población indígena, no indígena, entre los distintos ámbitos geográficos. Entonces es muy importante poder también estar considerando que todas las personas cuentan y si de hecho queremos no dejar a nadie atrás, es fundamental poder estar reconociendo que los distintos grupos de la población experimentan las barreras de acceso de manera diferencial e incluir esa consideración también no solamente en los procesos de análisis de barreras de acceso, sino también en las políticas públicas que tratan de abordarlas. El otro tema que también es súper crucial es el de la consideración de los determinantes sociales de la salud. Daría para toda una presentación, pero el ejemplo de las barreras de género yo creo que nos ejemplifica muy bien la importancia de esta situación. Si tomamos el matrimonio temprano, por ejemplo, que es muy prevalente en algunos de los países de la región de las Américas, nos damos cuenta que por sí solo el matrimonio temprano de hecho aumenta el riesgo de tener una mala salud sexual y reproductiva para los grupos de mujeres jóvenes y de niñas. Pero también así en los análisis que hemos hecho con las colegas de género, el equipo interprogramático que tenemos, nos damos cuenta también que son este grupo de mujeres las que experimentan con mayor frecuencia barreras de acceso que tienen que ver con su autonomía y que son también afectadas como producto del matrimonio temprano, con efectos muy negativos sobre la probabilidad que tienen este grupo de mujeres de utilizar servicios que son prioritarios para ellas y para sus hijos e hijas. No podría terminar la presentación sin hacer alusión a los tiempos difíciles que estamos viviendo con la COVID-19. En efecto, estamos a más de un año de la pandemia y los países de la región siguen reportando disrupciones en el acceso a los servicios esenciales de salud. Tenemos que casi el 50% de los países de la región de las Américas reportan que existen interrupciones en la provisión y en el acceso a los servicios esenciales, principalmente servicios de promoción y prevención desde el primer nivel de atención. Las razones son múltiples también. Son muchas de las barreras de acceso que ya yo explicaba en la presentación, pero también son barreras de acceso nuevas, producto de las nuevas dinámicas sociales y de las restricciones que ha traído la pandemia por COVID-19. Y eso lo que nos apunta es que hay nuevos desafíos para los sistemas de salud a modo de poder enfrentar las distintas barreras de acceso. Nada más me gustaría terminar la presentación con una invitación para que todos sigamos fortaleciendo nuestra función esencial de monitoreo y evaluación y en ese quehacer poder involucrar de manera sistemática el análisis de las barreras de acceso en todos los procesos, tanto de formulación como de evaluación de las políticas públicas que buscan fortalecer los sistemas de salud. Los países de la región, muchos de ellos tienen información ya disponible que nos permiten empezar a hacer ese tipo de análisis. Y en la medida que se fortalecen los sistemas de información, también se pueden estar empezando a incluir diferentes tipos de información. Como decía previamente, información cualitativa, datos administrativos, poniéndolos en un abordaje mixto o integral que permita conocer la realidad de los distintos grupos de la población en distintos contextos y para distintas condiciones de salud, a modo de que las estrategias que se generen estén informadas por esa información y actúen de manera efectiva sobre la realidad que viven diferentes grupos de la población. Muchísimas gracias por escuchar y de vuelta para ti, James.
Thank you very much, Natalia, for an excellent presentation. I take three messages, I think, from the presentation that I think are very relevant for all our participants today. First of all, it is important to measure access barriers, and it is very possible to do it. Many of the countries are moving in this direction, and it's something I think that we need to advocate for, to be able to examine those differentiated inequities that persist within our systems. These inequities and access barriers exist between countries and within population groups, and our policies need to be guided accordingly to address them. And finally, we need an intersectoral approach, really looking across all sectors to address the barriers that are persistent. So with that, I'd like to move on to our next speaker, who is Theodore Swift-Kohler. She'll be presenting on global initiatives and experiences in the identification and addressing of access barriers, its application for the Americas. Ms. Kohler is the Senior Technical Advisor for Equity at the World Health Organization in Geneva. Her current role, she promotes universal health coverage and supports member states in the assessment of health barriers experienced by marginalized populations. In addition, Ms. Kohler serves as a member of the High-Level Committee on Programs and Equalities Task Team at the United Nations Sustainable Development Group, Leaving No One Behind, and Human Rights Team. And she also participates in several interagency platforms for the eradication of rural poverty. She's published over 50 works and holds a bachelor's and master's degree from Stanford University. So over to you, Theodora.
Thank you very much. I'd like to ask if everyone can please see my screen.
We can see it well, Theodora.
Okay, excellent. So it's really a pleasure to be with you all here today. And I want to start by just saying really why is it so essential for us to be looking at barriers to effective coverage with health services. And I want to underline that first, it's improving overarching health system performance. Second, it's for reducing health inequities. Third, it's for improving financial protection. Fourth, it's for enhancing responsiveness to non-medical needs and ensuring integrated patient-centered care. And fundamentally, it's about ensuring the right to health for everyone. In WHO's 13th General Program of Work, there's a very strong focus on barriers, and the program of work explicitly calls out the Secretariat to do more with regards to its support to member states to address barriers to health services, and also commits the organization to working on normative guidance to support member states in doing this. For the work that is now underway in WHO headquarters, we are using the Tanahashi framework for effective coverage, which has availability, accessibility, acceptability, contact, and effective coverage delineated. A coverage curve, it clearly delineates the target population who do not contact services. In the slides that follow, I will go through each of these dimensions in depth. But I want to start really by saying a bit more about what we mean by effective service coverage. And we're referring to it being defined as the proportion of people in need of services who receive services of sufficient quality to obtain potential health gains. And with this, we mean really that we're looking at things like diagnostic accuracy, we're looking at treatment adherence, we're looking at provider compliance, we're looking at effectiveness of referral systems. So it is not only just service coverage, but it really delves deeper into these quality dimensions. Now, in HQ, currently, we are working on a handbook for assessing barriers to health services. And this builds on 10 years of work of trying out barrier assessment methods in different country contexts, collaboration with the different regional offices. I'd like to say we are very much inspired and learning from the work that is now underway in PAHO, and have exchanged on various occasions with colleagues there to learn from what you all are doing. In addition, over the last years, we have commissioned some reviews, some lit reviews of methods to assess barriers. And the one I'm showing on this slide is particularly looking at findings from a lit review that we commissioned to Johns Hopkins University. And it looked at across 3,274 different articles. We did an analysis of the article abstracts, reviewing a total of 7,212 barriers. We looked at how different types of barriers were covered by the articles, and we saw that often the articles, which predominantly, I have to say, focused on RMN-CH and HIV, predominantly they looked at availability and acceptability type of barriers. There was less coverage of accessibility, affordability, utilization, and effective coverage. Effective coverage, which as stated before, is very important to really delve into the quality and that ensuring that patients are obtaining the full intended treatment. That dimension was not well covered at all by the articles that were reviewed. In addition, we see that there's a mix in methods, that very few of them actually used a mixed method approach, which we in our work would definitely advocate for, because quantitative and qualitative together can provide very important insights that when you use one alone, you cannot. By adding qualitative onto quantitative, you're able to understand more of the compounding and intersecting effects that different barriers can have. And that is really important to understand if you were to design effective interventions to overcome them. So just to go through the different dimensions of the Tanahashi framework that we use, under availability related barriers, we have insufficient number or density of health facilities, inadequate number of appropriately skilled health personnel, scarcity of necessary health products inputs, and shortage or poorly functioning basic amenities like electrification, water, and sanitation. Under accessibility-related barriers, this is divided into 3 different domains. We have geographic transport-related, covering issues such as distance, availability of transport, time for transportation, and time is actually a really key one to look at different geographical landscape barriers, road quality. And then also under transport-related, we look at the autonomy in movement. And here I'd like to call out specifically a gender issue with regard to women and girls who may not have the same autonomy in movement without being accompanied by a male household member. Under accessibility, we also have financial related barriers, and that looks both at direct and indirect costs. Then we also have organizational and informational barriers, which relate to opening times, systems for scheduling appointments, administrative requirements like being registered in the local area, or for example, if you are a migrant who may not have the paperwork that is necessary to be able to access services in a given location. Information on the services in formats that are appropriate and that really reflect the cultural diversity and linguistic diversity of the population. And then also there are accessibility related barriers related to working in the informal economy, for example, not having paid sick leave to be able to go to an appointment. Some of the acceptability related barriers that Natalia has highlighted previously refer to culture beliefs about health and illness. They can also refer to the lack of connectivity integration between indigenous systems, traditional health systems, and conventional health systems. They also look at gender norms, roles, and relations that inhibit access, the age appropriateness of services, whether or not services are confidential. Perceptions of service quality can also inhibit people from seeking out care. And then also the safety of service delivery points, including not only in complex zones, but in locations, in neighborhoods where visiting those locations may pose different difficulties from a safety perspective. Discriminatory attitudes by providers as well, and this can be based on sex, ethnicity, marital status, religion, disability, sexual orientation, and all of these together, they often compound and intersect, and we need to look at them using an intersectionality approach. With regard to contact coverage in the Tanahashi framework, this really refers to the actual coverage between the service provider and the user, and this happens when services are available, accessible, and acceptable. And the lack of contact coverage we consider to be the foregone care. Now, coming back to the final level in the framework, the Tanahashi framework, is effective coverage related barriers. Again, as I said before, looking at diagnostic accuracy, insufficient provider compliance, weak referral and back referral systems, and then inadequate treatment adherence, which is often due to the patient-provider relationship, a mismatch between the treatment prescribed and actually the capacity of the patient to adhere based on their living, their daily living and working conditions, adverse socioeconomic conditions that may continue to negatively influence the health condition and that aren't being adequately accounted for, and gender norms, roles, and relations. So just coming now, after reviewing the framework, I'm coming now to the handbook that we are working on here in headquarters. And it contains different modules that can really support a research team in carrying out a barriers assessment. We have the preparatory stage that very much looks at alignment with the policy programming cycles. It looks at an inception meeting for convening key stakeholders, including government, academia, civil society, other key players, also from other sectors when appropriate. And then, of course, doing the research plan with the ethical review clearance. Then we have key informant interviews, delving into supply side issues. We have a literature review to really make sure that the barriers assessment would build on and complement the existing evidence and not, let's say, duplicate efforts. And then we have the quantitative analysis, looking at different data sources, focus groups that delve into, let's say, a deeper understanding of the demand side dimensions and also their perceptions, the population's perceptions at different subnational locations of the supply side issues. And then we have the module 7 dedicated to the data triangulation across the different sources, and then really synthesizing the findings cohesively in reporting, and then taking it on to the workshop, which is aimed for not only dissemination, but really it's when we start moving towards the identification of entry points for change and acting on these different barriers. And the same stakeholders that have been involved across are convened again, possibly with additional players that are very important for different barriers that have been identified, to look at mapping out the way forward. Now, I'm going to take you quickly to Mongolia just to share in a snapshot an example of how we also used barriers assessment and the Tanahashi framework in mapping out barriers for a patient pathway. In particular, this you're seeing here, the patient pathway for treatment of cardiovascular disease in a rural and remote area. And you're seeing the participants all from subnational government come together and really look at, okay, drawing on aspects of the Tanahashi framework, what are the key barriers that emerge at different stages in the patient pathway? And then they looked at considering what could be done in the context of their 4-year plan. And here in the lower left-hand side of the screen, you're seeing the workshop agenda that we used with them for 3 days to really explore how to integrate barriers and a response to those barriers, research also to look at more the feasibility of certain responses, how we could work that into their subnational 4-year plans for health system strengthening. And here also are just some summaries from different countries that we worked with on assessing barriers, some different summaries of the barriers that emerged for the rural poor in particular, and areas that we saw that there was a clear need for address in policies and programming. So just a final word on our global work. We are also expanding on how our methods unpack affordability related barriers. And here we're looking at how they can take a more systematic, we could take a more systematic approach for looking at, for example, population coverage with financial protection linked to eligibility, procedural issues in registration, renewal, lack of awareness of entitlements and issues regarding perceived quality of the benefit package, issues related to the depth and breadth of the benefit package, explicit health financing rationing instruments such as direct cost of premiums, formal and informal user fees, co-payments, deductibles, and then indirect costs, for example, with regard to transport and accommodation and other barriers. So just in terms of some resources available now online, over the course of the past years, we've, in working up to this cross-cutting global guidance that can be used in primary healthcare strengthening, in reforms towards universal access in UHC, we've been working on different thematic areas. One is on adolescent health services, and there is a guide now available online that really delineates the methods, and I encourage you to look at that, and then also to look at Innovate. Actually we collaborated quite a bit with countries in your region for the original production of this, but the Innovate approach has a whole module dedicated to Tanahashi and exploring barriers, including through lit reviews. So we encourage you also to look at that. Thank you very much, and it's really an honor to be with you discussing this, and thank you again to PAHO for their leadership in this area.
Thanks very much, Theodora, for a very informative presentation. A couple of key takeaways I see. Obviously, the wide variety of methodologies that are out there, the importance of not just looking at the issue of availability, acceptability, and affordability, but really drilling down and looking at the issue of effective coverage, which is critical. And the need for rigorous methods in application to really to be able to draw out the information and generate the evidence required in order to guide decision-making within health systems. So thank you very much for that. We will now move on to our next speaker, who is Federico Guanais, the Deputy Head of the Health Division of the Organization for Economic Cooperation and Development. Dr. Guanais has worked in health development and public policy for more than 20 years. Currently, he supervises the technical work in the areas of health statistics, health systems performance, patient-reported outcomes and experiences of care, and primary care at the OECD. He is also engaged in providing scientific and policy guidance to countries in the pursuit of high-performing health systems. He's been published in several academic journals, having received Paper of the Year award for a study on the integration of health and social care, published by the American Journal of Public Health in 2013. He holds a PhD in public administration with a focus on health policy from New York University. And he'll present for us here today on access barriers and experiences in primary healthcare in the region of Latin America and the Caribbean. Federico, it's a pleasure to have you. Over to you.
Thank you very much, James. It's quite impressive to see the convening power of PAHO. I mean, the leadership that you have with over 450 participants. And every time that I check the number keeps growing. So it would be my pleasure to share some of the reflections that I have today on this topic. Let me see if I can get my screen to share. All right. Can you confirm? Can you see my screen? Not yet. Maybe now.
Yes, we can see it now, Federico.
Okay. All right. So now let me just do this. So right, and I would like to thank Natalia for reaching out and then to bringing this topic and asking me to talk about access, and also from the perspective of the patient, right? From experiences from the perspective of the users of healthcare. So, and when I went back to look at the data, it's interesting to see that when you ask the people, and this is based on a survey that the Commonwealth Fund has been conducting from several years in 11 high-income OECD countries. And when I was at the IDB, the Inter-American Development Bank, we replicated that same survey for 6 countries in Latin America and the Caribbean. So that's a strong focus on primary care. But I think that the interesting thing of this survey is that asking the users themselves about their experiences of healthcare. So when you ask the people about the last time when they needed, whether they could get a primary care appointment in the same or next day, about half of the people say that they could get an appointment. And what struck me was that the difference is not that large between Latin America and the Caribbean and the OECD countries on average. However, if you look closely, it does have an important equity gradient by level of education in Latin America and the Caribbean, which is a proxy for income. So you see it goes from 44% to 52% to 56% when you go across increasing levels of education. But so I think that there's the first message is that, well, that's right. I mean, the differences in access to actually get an appointment in primary care are not that high, but this hides the issue of equity that's mostly associated in the countries in Latin America and the Caribbean. But if you actually move the perspective to looking into financial barriers to healthcare, and then we see that the problem is even more complicated. Here is a graph that shows the percentage of people who had a problem but did not see a doctor or skipped a test or treatment because of cost and had serious problems paying for healthcare, comparing Latin America and the OECD. And here the differences are much more striking. There's also a gradient by level of education, and therefore as a proxy for income in both countries, but in both groups of countries. But it is much more important in the countries in Latin America and the Caribbean, when you see the problem of delayed or foregone care due to financial barriers are very, very important in the region. And if we move even one step further in terms of, okay, what's the kind of care, that access to healthcare that these people are having in both group of countries, we see that the problems are even more complex. Here is a graph that compares the percentage of people who had what we are calling person-centered primary healthcare. And that is a composite index that takes into consideration 4 elements. The first one is whether the person has a regular doctor or place of care that knows their medical history, that's easy to contact during regular office hours, and that helps to coordinate care. And here, there are a couple of important messages. You see that even in OECD countries, fewer than half of all the people who responded said that they have primary care within these 4 characteristics. But when you look into Latin America, that's even much lower, around 10% for those who have primary or secondary education, and around 20% for those who have higher education. So here's one important thing. Approximately half of the people say that they have access to an appointment, but it's basically what kind of appointment? Is an appointment to a place that they use regularly, that know their history, that helps them to coordinate care, all of the things that we've been talking so much about, the attributes of strong primary health care. And here, I think that what we have in times of COVID highlight the importance of these things even more strongly. Having a regular place of care is an indication of also of the trust that you may have within your healthcare providers. Whether they know your medical history, for example, in times of COVID, it's key to allow for the providers to know, well, who are my patients who have previous existing conditions? Who are my patients who should be prioritized, for example, for receiving vaccination? And also in terms of the communication, is it easy to contact the care providers in case of need? So, and I think this highlights the important point that we might be talking a lot about the access, we might be talking about barriers, but we also should be looking into from the perspective of the patient themselves. What is the experience that they have when they're actually accessing primary care? In times of COVID, these things become ever more important. And now, as if this was not enough, we see that the COVID-19 has renewed challenges for primary healthcare everywhere. So even if we look into the OECD countries alone, so what we saw is that with the COVID pandemic, there was a drastic reduction in the volume of primary health care consultations during the first wave. I mean, the graph that you see here is graph for the spring of 2020, the spring in the Northern Hemisphere, meaning compared to the spring of 2019. So you see that across OECD countries, up to 50% of consultations were reduced compared to the previous year. So, and this is creating such an important backlog that's going to necessarily be dealt in the future by primary care and by other levels of care. So we give a few examples. In France, the number of cancer diagnoses decreased by 35 to 50% in April 2020 compared to the year before. This means that a lot of the people who could have been detected very early with better prospects of treatment will probably have dire outcomes and prospects because their conditions have been detected much later on. Similarly, in the Netherlands, the number of cancer diagnoses decreased by 26%. So so it's important that we already have important challenges in primary healthcare, and COVID made them even more apparent. And I'm sure that in Latin America and the Caribbean, a similar trend took place. So one thing that I keep telling, and actually I was talking to James the other day about this, is the issue that we do have a policy window that's open for the discussion of health investments in healthcare. And I think that the worst thing that can happen is that all of these investments goes towards to the things that perhaps are in lots of people's minds, which are the acute care, which are the intensive care units, which are only the treating patients in the last mile. Of course, it's important, and we recognize that the region has shortcomings in terms of the access to hospital beds and ICU beds. But who are the patients who are most likely to end up in hospitalization and with a severe case of COVID are precisely the ones who have a pre-existing condition, who have a risk factor such as obesity. So keeping a strong, resilient population also is a part of having a strong, resilient health system in the future. And here are the things that primary care can and should be doing during times of pandemic. So first of all, the continuity of care, taking care of people with the chronic conditions, help them take care of their conditions without interruptions that we see in continuing the vaccination and screening programs, community engagement, and so on. But during the acute phase of the pandemic, we saw very little discussion of what's the role that primary care could have in even the tracking and tracing of the COVID patients, caring for the mild COVID patients, following up after the hospitalized patients come back to the community, and promoting public health measures. Very often, primary care was not even equipped to do these things, for example, with access to enough tests and so on. And in the aftermath of the pandemic, we foresee really an important backlog of cases of patients who suffered the direct and indirect effects of COVID crisis. Those who had delayed and foregone care, those who have COVID and are suffering for long COVID, those who have mental health consequences of the pandemic. So here, I think it's time for renewed surveillance and care models that we can think of primary care in the future. And also moving forward, I would like to show this slide to close my presentation with a discussion of an initiative that we're conducting right now. So these are usually the aspects of the health systems that we're measuring, including the barriers. I mean, what's the characteristics of the delivery system? What are the individual and social demographic factors? What are the capabilities of the healthcare system? What are the health behaviors, and so on? But what is it that we're missing from this picture is the patient-reported experiences of care and the patient-reported outcomes of care. So there's no sense talking about whether the roles of primary care are being fulfilled unless we have information that's reported by the patients themselves, right? Even the classic Barbara Starfield characteristics of primary care of access, comprehensiveness, continuity, coordination, these are the things that we should be asking the patient themselves to report on these indicators. And also in terms of the patient-reported outcomes, we're maybe talking about hospitalization and death, severe outcomes, but how are people extracting or being able to have strong quality of life, function, lack of pain, self-reported health, and so on? What are the outcomes that really matter to the people? And that's why at the OECD, we are conducting now, we're working hard to put in place a new generation of health systems indicator. This that I'm showing there is the number of countries that have signed up to participate in what we're calling the Pisa for healthcare. I'm sure many of you know the Pisa, the Program for International Student Assessment, which is the OECD evaluation of educational systems. Now we're working to put together the Paris, which is going to be the patient-reported indicator surveys. Right now, we're piloting this experience in 20 countries. We have Spain, we have Portugal on board, so we're going to have questionnaires in Spanish and Portuguese, of course, English and French as well. So I think it would be a shame if we didn't have also this data for Latin America and the Caribbean. We're still working on that, we're still developing, but I would like just to plant the seed of this conversation that if we want to know what matters most in terms of the access and the outcomes that people are experiencing, we should ask the patients themselves. Thank you very much. I'll leave you here my contact details. Over to you, James. Thank you.
Excellent, Federico. Thank you for that excellent presentation. It's very interesting to see the parallel situation in OECD countries and all other countries in Latin America and the Caribbean with regard to the impact of the pandemic in access to essential health services, very similar trend. And of course, we note that the financial barrier is, if not the principal barrier, one of the principal barriers to access healthcare services in the region of the Americas, constituting up to 30 to 60% of health financing at this point in time. We also recognize, I think, as you very well pointed out, the importance of really zoning in on patient-centered care, people-centered care, and beginning to work with the person, with the patient on their needs and what their perceptions of quality integrated care is, and what the perception is in terms of access barriers. And this links in very well with then the discussions we were having on the need for more resilient health systems coming out of COVID-19. PAHO is preparing at this point a policy document for our member states on resilient health systems that is very much based on a primary healthcare approach to accelerate the recuperation of lost public health gains that we'll be presenting in the executive committee meeting in May. So thanks, Federico. I will now move on and ask my colleague, Ernesto Bascolo, who is the Regional Advisor on Health Governance, Leadership, Policy and Planning at PAHO, to give us a few remarks. Ernesto is an economist with extensive public health and research history. He holds an MPH, a Master's in Health Economics, and a Doctorate in Social Science. He is responsible for the regional agenda of PAHO's technical cooperation in the measurement and strengthening of the essential public health functions in the Americas. So over to you, Ernesto.
Muchas gracias, James, y buenos días a todas y todos. Quiero tomar unos minutos para hacer un cierre de este encuentro y repasar, serían los mensajes claves de lo que hemos encontrado hasta ahora en las presentaciones. Lo debía dividir en tres partes, ¿no? La primera parte, tratar de recuperar el seminario actual, el primer seminario, en el marco de la serie de seminarios de funciones esenciales. El segundo, cuáles fueron los mensajes más importantes de las propias presentaciones, y por último, los próximos pasos, digamos, ¿no? de este conjunto de actividades. Bueno, hemos comenzado este seminario enmarcado en el nuevo marco conceptual de las funciones esenciales de salud pública, como lo ha planteado el doctor Barbosa, y en los objetivos de la estrategia de salud universal, ¿no? En un contexto de extrema complejidad por la pandemia del COVID, por sus consecuencias sanitarias, epidemiológicas, pero también económicas y sociales. Hoy más que nunca debemos expandir y fortalecer, creo que ha sido muy claro, el campo de saberes y de prácticas y de competencias de la salud pública, ¿no? Ubicando a las funciones esenciales de salud pública con una orientación estratégica de la función de rectoría de las autoridades de salud e involucrando, esto es una misión inevitable, a una acción colectiva muy amplia conformada por expertos científicos, los equipos técnicos de los ministerios de salud, equipos de salud responsables de la producción de intervenciones de salud directamente, y también a la sociedad civil, a todos sus miembros, y fundamentalmente a través de sus organizaciones. Como vemos, gran parte de estos actores incluso nos están acompañando, ¿no? En todo este proceso, en estas actividades. En el marco de la Estrategia de Salud Universal, el acceso a los servicios de salud ha sido pero hoy más que nunca una dimensión central que interroga la capacidad de respuesta que tienen los sistemas de salud a las necesidades de salud de la población. Y es por ese lado, en ese sentido, que sirve para interpretar en qué medida nuestros sistemas de salud responden y se adecúan a esas necesidades, ¿no? A las expectativas y a las condiciones culturales, sociales y económicas de la población. Es como un puente para interpretar la relación entre el desempeño que tiene nuestro sistema de salud y las reales necesidades de salud de la población. Más aún, el análisis de acceso y las barreras al acceso a los servicios de salud, como los expositores nos han comentado, incluso tiene un alcance que va más allá del desempeño de servicios individuales. Y es por eso que tiene una gran pertinencia en la agenda de funciones esenciales en salud pública, ya que tiene la potencialidad de reconocer las fortalezas, pero también las limitaciones de las capacidades que tienen nuestros sistemas de salud, y especialmente de la función de rectoría de las autoridades de salud para garantizar que esas intervenciones de salud pública aborden en cada contexto, en cada comunidad, los factores de riesgo, de salud ambiental y los determinantes sociales de la salud. Tenemos que reconocer que a pesar de los avances que ha tenido la región, en todas las presentaciones esto ha sido muy claro, a pesar de los avances en las últimas décadas de procesos de reforma de los sistemas de salud, cuando analizamos las barreras al acceso a los servicios de salud, esto todavía es un desafío pendiente. Por ese motivo, la medición de estas barreras es una capacidad crítica que deben asumir, que tenemos que asumir, y fundamentalmente las autoridades de salud en procesos de formulación de nuevas políticas para responder a los reales problemas que tiene la población en cada uno de sus contextos. Pero bueno, otro de los mensajes clave ha sido un llamado a la acción, ¿no? Digamos, uno de los elementos fundamentales es cambiar la forma en que pensamos las barreras al acceso a los servicios de salud, ya como un ejercicio que tiene que estar intrínseco en el ciclo de la formulación de políticas, ¿no? No solamente como una etapa de evaluación previa, sino como un elemento que debe atravesar las distintas etapas del ciclo de formulación de políticas de salud. Bueno, las iniciativas que estamos implementando desde la organización, como se ha comentado, tienen justamente el objetivo de apoyar a los países en esa tarea, y las funciones esenciales en salud pública son un excelente guía para una hoja de ruta que busca fortalecer justamente esas capacidades críticas en los países. El segundo tema, con respecto a los expositores, nuestros invitados han compartido aquí una variedad de elementos, ¿no? No solamente abordajes conceptuales, metodológicos, sino también resultados muy interesantes que sirven para interpretar la magnitud de los problemas relacionados con las barreras, cómo se manifiestan, qué manifiestan las barreras cuando interpretamos este tipo de indicadores, y cómo traducir esta información como un insumo en la formulación de políticas. Conocimos el marco metodológico y conceptual que está utilizando la Organización Mundial de la Salud, y de paso digo también la Organización Panamericana de la Salud, repasando los diferentes tipos de barreras que se relacionan con las dimensiones del marco de Tanahashi, pero también Federico nos ha mostrado un marco conceptual, analítico, con indicadores, dimensiones y dominios muy interesantes, con varios puntos de contacto, digamos, con el resto de las organizaciones que están abordando esta temática. Ahí creo que se abre un diálogo de cooperación y de trabajo conjunto para fortalecer estas capacidades en los países, muy importante. Nuestros invitados también han reflexionado sobre las barreras a partir de análisis concretos de contextos particulares. Esto es un elemento para nosotros fundamental. Hemos tenido la oportunidad de profundizar una mirada de datos que nos permiten, en primer lugar, perdón la reiteración, no creo que a nadie le pase desapercibido que prácticamente una tercera parte de la población enfrenta algún tipo de barreras cuando tiene necesidad de servicios de salud. Y este es un dato muy estructural que al mismo tiempo tiene un peso mucho más significativo, no solo en los países de ingresos medios bajos y bajos, sino fundamentalmente a través de a la población en condiciones de mayor vulnerabilidad. Bueno, otro de los elementos que también ha sido un punto en común tiene que ver con ponderar el primer nivel de atención y ya no solo como un objeto de análisis para interpretar las barreras, sino como una de las líneas fundamentales para transformar los sistemas de servicios de salud. No quiero extenderme más, pero se han desarrollado conceptos muy importantes con respecto a los distintos tipos de barreras, como el tema de la aceptabilidad, la financiera, disponibilidad, geográficas y organizacionales. Cada una de ellas importa, pero también importa las relaciones entre las mismas y por sobre todo importa cómo impactan en distintos contextos, en distintos territorios, para distintos grupos sociales y problemas en particular. Bueno, como mencionaba al principio, este es el primer seminario de una serie de seminarios virtuales. Este seminario es un paso más para expandir una comunidad de actores comprometidos con el tema de la salud pública. Quiero agradecer especialmente a Teodora, a Federico y a Natalia por sus exposiciones muy contundentes, muy ricas en conceptos, pero también en datos, que me parece que nos alientan terriblemente para una discusión y para una hoja de ruta para profundizar sobre esta temática en el marco de funciones esenciales en salud pública. Quiero aprovechar también para decirles que vamos a hacer este tipo de actividades en forma prácticamente mensual de acá a fin de año. El 17 de mayo presentaremos el marco de monitoreo para la salud universal y abordaremos los desafíos y experiencias relacionados con la función de evaluación y monitoreo y la necesidad de promover la producción y utilización del conocimiento al servicio de los procesos de formulación de políticas. Después se derivan un conjunto de temas que de alguna forma van acompañando el ciclo de políticas que es el marco conceptual del marco de funciones esenciales en salud pública. El tema de legislación y políticas, el tema de resiliencia, el tema de financiamiento de bienes públicos para asegurar el ejercicio de las funciones esenciales, el tema de recursos humanos a través del análisis de las competencias que son necesarias para hacer efectiva estas funciones esenciales, el tema de factores de riesgos y salud pública ambiental, uno de los temas, digamos, como un corazón fundamental para de estas funciones esenciales en salud pública, y no quiero dejar de mencionar el peso que va a tener la participación social y el abordaje sobre los determinantes sociales de la salud. Bueno, sinceramente creo que aparte de los expositores, quiero aprovechar para saludar y agradecer no solo a todo el equipo de HSS, sino a todos los colegas de los distintos departamentos que hacen posible que este tipo de actividades podamos llevar adelante, a los intérpretes, por supuesto, a los expositores de nuevo, y en especial a todos y todas que nos están acompañando, no solo los que están presentes, sino los que nos van acompañando en el conjunto de actividades que busca fortalecer la agenda de funciones esenciales en salud pública como una agenda para fortalecer los sistemas y de alguna forma mejorar la resiliencia en este contexto tan complejo. Muchas gracias, James.
Thank you very much, Ernesto, for that excellent summary. So we are almost coming to the end of this webinar. Unfortunately, we didn't have sufficient time to have a round of questions and answers. I think there was a lot of excellent information presented in the presentations. I think the words from our Assistant Director, Dr. Barbosa, really framed the discussion within the context of the transformation of health systems within the Americas towards the achievement of universal access to health and universal health coverage based on the primary healthcare approach, and having the essential public health functions as the core architecture to really strengthen public health capacities, so that we're having a more integrated approach as we strive to ensure universal access. At the same time, we are building the level of resiliency within our health systems. I too want to thank all the excellent presentations that we have received here today, from Natalia, from Theodora, from Federico, and of course the inputs from our own team. I think it's very clear that this must be a priority area of work in the region of the Americas if we're really going to generate the necessary evidence that we need to transform our health systems through evidence-based policymaking. If we don't have this information, if we don't have the data in the analysis of the barriers that exist within our health systems, well, then we cannot induce change. And it's that induction of change that we really need to promote as we strive forward in the transformation of our health systems. So I am urging all our participants to look into this in more detail. I'm inviting our member states and our countries to contact us, and we will work with you on the development of these methodologies at the national level through our country offices, and of course with our partners in WHO and the OECD as we move forward with this very important agenda. Dr. Etienne always talks about the need to leave no one behind. And if we're not going to leave anyone behind, we need to know what the barriers are that is impeding access to health within our health systems. And so this work is really a fundamental and core pillar moving forward. We've had over 500, we've had approximately 500 participants in this session today. We will have the session on YouTube. It's also being streamed live on YouTube. We have some questions that we will respond to in the chat on some specificities around the relationship between access barriers and types of health systems. Others relating to COVID-19 that I think were addressed in some way during the presentations. And the presentations, I believe, have been made available through the links for this meeting. Finally, before I close, I would like you all also to make sure that you register for the next webinar on essential public health functions. This is scheduled for May 17th, and it will be entitled Monitoring Universal Health in the Era of COVID-19, where we will delve a lot more into some of the issues around the impact of the pandemic on some of the elements that we really require to build health systems moving towards universal health. In particular, also looking at the impact of COVID-19 on what has happened in the provision of essential health services. With that, we will leave you. Many thanks again. And